Everyone, and thank you for joining us at the COS session at this wonderful AIOS. Um, as we all know, that ophthalmology is no longer practiced in silos, and there are multiple subspecialties, and we all bank on each other to offer the best care to our patients. So here we have a gamut of talks by the most renowned speakers from Chandigarh, and they'll be covering all the subspecialties. So without much ado, I invite our first speaker, Dr. Praveen Sen, for her talk on inherited retinal disorders.
A very good afternoon to everyone, and thanks to Dr. Parul for having me here and talk on my favorite topic, which is the diagnosis and management of inherited retinal diseases. It's a very vast topic, but I'll try to just give you an overview of how I do and how we do things now at this part of the journey where ocular genetics is becoming more and more relevant. So, inherited retinal dystrophies, these are a few which I have um, put up. It's not the exhaustive list, just to show the common ones. And though they belong to the rare eye disease category, they are in toto, when they are put together, they are no more rare. Almost 20 to 25% of blindness in the working age population is due to IRDs, and more than 300 genes could be associated with IRDs. And the new standard of care in IRD is early diagnosis, characterization of disease, genetic testing, counseling, and familiarity with the ongoing clinical trials. No longer can you just tell the patient that nothing can be done and the patient goes home. No, you are entitled to do these things properly, because very soon we are at a horizon where we will have treatments available, and the clinical characterization or the deep phenotyping involves not only just imaging but detailed history taking, visual acuity, fundus examination, multimodal imaging, and electrophysiology. Sometimes the smallest of things are very important. You should not miss this, that a lot of patients may have a refractive error. In fact, myopia, simple patient comes to you in your clinic of myopia, maybe actually a patient of IRD. If you ask for a history of night blindness associated, definitely it will be a congenital stationary night blindness. Patients with CSNB tend to be myopic, and especially the TRPM1 gene associated CSNB is a myopic refractive error. And functional assessment, especially perimetry, to look whether it is the central area which is involved or the peripheral area which is involved. Electrophysiology can be diagnostic in so many cases. You can actually sometimes in some cases figure out which gene is causing this defect by simply doing a good electrophysiological test. Typical ERGs are seen, as I said, in things like enhanced S-cone, where you will have, if you just do an ERG, it is enough to let you know. This is something very typical, that it is NR2E3 gene which is causing this enhanced S-cone. If this is a case of cone dystrophy, and if you see a flat photopic response with supernormal scotopic responses, it is a KCNB2 gene which is causing cone dystrophy. So a good phenotype and then a phenotype genotype correlation can go a long way in helping our patients, even reaching a genetic diagnosis without doing genetic testing. Wide field photography is very important. You can see, if you just see this picture in the left, you will think you are dealing with a macular dystrophy, but if you see a wide field image, you see that lot is happening in the periphery as well. And when I did the genetic testing for this patient, this was nothing but circle mutation causing retinitis pigmentosa. This is another patient, 10-year-old child. What you need to miss, a lot of us on a cursory examination would say that this is a normal fundus, but actually this is not normal fundus. If you look carefully, these are this white RP granularity or dots which are seen. And having seen a lot of patients with this kind of presentation, I got a genetic testing done, and this patient also had circle mutation causing RP, even though the child had 6/6 vision. But having had the diagnosis so early in life can help in prognostication and him to plan his future life. Again, this is typical of Crumb's protein. Not all RP comes with bony spicule pigmentation. This type of coin-shaped pigmentation is typical of CRB1 gene causing it. This typical presentation of a macular coloboma is due to RDH12 gene causing retinitis pigmentosa. Autofluorescence is very important because it shows the deposition of lipofuscin, and we know in IRDs the lipofuscin is the distribution of lipofuscin can give you the diagnosis in some cases. Peripapillary sparing of FAF seen in patients with ABCA4 retinopathy is very, very typical and specific. So fundus autofluorescence along with OCT can help you in prognostication. In fact, the newer gene therapy trials which are done, they look at how much of the EZ is remaining for the patients to be enrolled into the trials. So it is important to do a deep phenotyping of these patients. To see the underlying genetic disease, it is important to do genetic testing because more than 300 genes can cause IRDs, and just putting them into a pool of IRD is not fair to the patient. So the American Academy of Ophthalmology has said that genetic testing is mandatory for diseases like LCA, especially because gene therapy is now available. So it is up to the patient to decide whether he wants it or not, he can afford it or not, but you must do and tell the patient that this is what is done. Also, they have recommended that for monoocular or monogenetic diseases like RP and Stargardt's, genetic testing should be done. It helps in proper diagnosis and proper genotype phenotype correlation and prognostication of the disease, especially in children. This may be associated with the syndrome, and you may be the first one to find out whether the child is suffering from a underlying systemic disorder. So what are the tests which can be done? So this is something which we all need to learn, that this is when you do it can be a single gene test which can be more expensive, or it could be just a whole exome can be tested or a whole introne can be tested. Interpreting the genetic testing. Thank you. So when you start venturing into this thing of genetic testing, you have to see how do you interpret it. This is also important. The whole classification is done based on the American College of Medical Genetics and Genomics, and this is how they describe it: the variant as pathogenic or likely pathogenic, or variant of unknown significance. So here you know very clearly, anybody in the house can tell that this is retinitis pigmentosa, but when you do the genetic testing, you see a typical gene, but this is not always the case. Again, a phenotypically typical RP, but no gene has been seen. This does not mean that it is not a genetic disorder, but that you may be looking at a new gene which is causing it, or a sufficient kind of correlation has not been able to be established. Another case, typical RP, but no gene variant has been recognized. ABCA4 is another one which could present in a different phenotype, and you may not always, there are other genes like PROM1 or ELOV or PRPH12 which can have a similar phenotype as ABCA4. So genetic testing is extremely important. Only then you can finally be able to pool these patients into which type of patient can go into which kind of therapy. So this is an example of a patient who underwent genetic testing, and the child had CEP290 mutation, and the child was ready to go for genetic testing, and so we gave them that this kind of genetic testing trial is happening in US, and the patient was actually ready to go to US and get enrolled in this CEP290 trial. So there is importance that you should know familiarity with the ongoing clinical trials, what is happening. Sometimes patients can actually afford and go and get this kind of treatment. So some trials which are happening are ARSTAT trial, the choroideremia trial, the X-linked retinoschisis trial, achromatopsia trial. So these are the few genes which are already into phase 3, phase 4 clinical trials, and so definitely importance to diagnose these kind of patients so that you can counsel your patients regularly. So when you are incorporating these genetic testing into your system, most important is genetic counseling. This has to be done before the testing as well as after the testing. Before the testing, you must tell the patient that only in 70% of the cases you will get a positive response. Some cases you may not get, and what are the implications. So this is a pre-test and a post-test counseling. It is important. Another example of post-test counseling, this patient was an albinotic patient. We have seen these kind of cases many times in our clinics, but we don't get genetic testing done. I got the testing done here. Patient was diagnosed to have Hermansky-Pudlak syndrome. importance. Genetic counseling is extremely important because they can be associated with uh, uh, granulomatous colitis and will need to have systemic therapy for the same. Bottleneck, not everybody can afford it. So this is where we all need to come together and work towards forming a registry, forming support programs which can help us increase genetic testing for our patients. Thank you.
Thank you, Dr. Praveen. That was a very, very enlightening, compact talk. While I request Dr. Sartaj to please take the stage for the next, I request Professor Jagatram, Professor Dogra, please, as panelists, to join us on the stage, please. And meanwhile, Dr. Dogra, if you could have one comment or question. Professor Dogra, your take, one point, take home from Dr. Praveen's talk.
Thank you, Dr. Praveen, for such an enlightening talk. I think what is important at this time for all of us to know is, like she already mentioned, even if we can tell a child, you have just one child, they keep on going from places to places. And if you can tell that this is not going to progress, this is going to remain the same, I think it made the whole life for the family. And not only that, you may have something which is very fast progressing. So they have to plan differently, you see, and then some of the therapies she mentioned about. And then at the same time, there could be diseases which may have some kind of a treatment, maybe supportive or something which helps. So I think this area is becoming more and more important. And for us in retina, I think almost 35 to 45% of the diseases associated with retina, where perhaps we were not even looking at them seriously. These are inherited retinal disorders. I must congratulate Dr. Praveen for such a wonderful talk, as well as telling us all that what all we should be doing, especially in these kind of commonly encountered problems in retina. Thank you.
Sir, if you could please join us. Dr. Jagatram, please, sir, come up.
So, Dr. Sartaj would be talking to us about recent advances in ocular surface disorders. Over to you, please.
Good afternoon. I'd like to thank Dr. Parul for this opportunity today. So, I'll be talking about recent advances in ocular surface disorders, and I'm going to mostly just stick on the third edition of the dry eye workshop that was conducted last year. This is a very exhaustive and comprehensive resource on understanding dry eyes, on understanding what is the current research in dry eyes and the best available treatment modalities. So the Indian and I'm going to be trying to present the TFS, the DUCE 3 from the Indian perspective, that what is relevant for us. So we all know, anyone who sat in an OPD knows the prevalence of dry eyes. The studies show that it's at least 26 to 32%, but anecdotally, I'm sure most of us would say that it's much more, going by the complaints that we listen to in our OPD. And specifically in India, we have a greater adoption of digital screens. You have a very prominent IT sector where patients are spending a lot of time on screens. That is a factor that can lead to a lot of dry eyes. Our climate is such, we have a high amount of UV exposure, especially in the plains. That's another factor. There's still a rural population that is using biomass for fuel cooking. Chemical burns are quite common amongst construction workers, lime and caustic soda, and that's a leading cause of limbal stem cell deficiencies. There's also a huge burden of systemic diseases which are also associated with dry eye disease, such as diabetes and autoimmune disorders. Basically what has changed from the dry eye workshop from 2 to 3 is essentially that now, in order to classify it as dry eye disease, the patient has to be symptomatic. If you simply see signs on the lid or on the surface of the eye, you will not really go ahead and diagnose it as dry eye. The patient has to be symptomatic. And also, going from this binary classification of just aqueous deficiency versus evaporative dry eye, we now have 9 different etiological subtypes, which are across 3 different categories shown here at the bottom, which is basically tear film deficiencies, which can be lipid, aqueous, or mucin or glycolalic deficiency. You can have eyelid abnormalities, such as any movement disorders, blink reduction, or lag ophthalmos. You can have lid abnormalities such as MGD or blepharitis. And an ocular surface, you can have anatomical misalignment such as pterygiums or conjunctival chalasis. You can have neural dysfunction, you can have cell damage, or just inflammatory disorders. Along with the diagnostic thing, even the management approach has changed from rather than a stepwise management approach where you are titrating or increasing the treatment depending on stage. Now it goes more on evidence base and based on what is the cause or the culprit of the dry eye. You will sort of concurrently start different treatments at the same time. And also, it's provided us with this excellent tool, the OSDI 6, which is just 6 easy questions which you can ask even in a busy OPD. A score more than 4 is very useful for screening in patients with any kind of dry eye disorder. After you have a positive OSDI, the next thing you can do is you can actually confirm that diagnosis. And the DUCE 3 has said that a non-invasive tear breakup time of less than 10 seconds, or a tear osmolarity if you can of more than 308, or if there is staining on the surface, which can be on the conjunctiva, the cornea, or the eyelid. Both of these, if any of these is available or is seen, then that is confirmatory for dry eye diagnosis. Then the next thing you want to do before treating is try to classify it, identify what is the source. Is it the tear film? Is it the eyelid? Or is it the ocular surface? So most of these things can be done very easily in an OPD. If you don't, and there are devices available that can carry out a NICBUT very easily and quickly and reliably. But even if you don't have that, just doing a fluorescein staining and monitoring that is also as effective. Obviously, not everybody would have access to tear osmolarity. But it says that even if you use just a Sandy score, which is a very just a 2-factor sort of scale, it's very easy. Even just monitoring blink movements, there are apps that can do that. And again, just fluorescein staining of the corneal surface can really help you with the diagnosis. In terms of management, so you basically have different algorithms, which is based on what is the driver of the disease itself. Is it the tear film, the eyelid, or the ocular surface? In case of the tear film, the drivers could be, again, any of the deficiency of lipid, aqueous, or mucin. So you have a few different drugs. You have Meebo, which is not available in India right now, but we do have cyclosporin, lifitegrast, and trehalose-based lubricants, which are easily available. We do have some newer molecules also, Triptor, which are basically going to break down the keratin that is present on the glands. And you have punctal plugs, and now you also get basically these filler-based cross-linked hyaluronic acid punctal plugs, which you can implant, and they can be easily washed away with saline or dissolved, and without any scarring. So for patients where you feel they might not need the punctal plugs permanently, or you might be worried about epiphora once, if you remove the punctal plugs and there's scarring, that's a very good option. In terms of eyelid, for MGD and lid margin diseases, you have the standard of warm compresses, lid hygiene. You have ointments which use selenium sulfide, which again help with keratinic deposits on the eyelid margin. You have Xtemvi, which is very good for Demodex infections. You have the standards of IPL and other thermovectoring modalities such as LipiFlow or tear care. And you have blinking therapy, where you can just give the patient simple exercises. For ocular surface disorders, you have newer sort of molecules that are available rather than immunosuppression in the form of just steroids or cyclosporin or tacrolimus. You now have these JAK inhibitors which are in the pipeline, which are supposed to be much safer and more effective. And you obviously have surgical modalities such as SLET, which has been invented in India itself and is a matter of great pride for us, and other procedures such as pterygium excision to get rid of any anatomical anomalies. There are new pharmacotherapies that are available, along with the Meebo that I just discussed. You also have newer water-free cyclosporin molecules, which should be much more comfortable, because anyone who's experienced cyclosporin will tell you that there is a reasonable amount of stinging that happens after instilling the drop, which can sometimes be a real hindrance for compliance with these. You have nasal sprays available, Tyravaya, which is shown to increase tear, oil, and mucin production simultaneously. But it's again not available in India right now. And for Demodex, you have the first FDA-approved treatment, which is the Xtemvi. Again, it's an anti-parasitic, good for blepharitis, but again not available in India as of yet. Tea tree oil, we all use that off-label. In India, we use cyclosporin quite a bit. 0.05% is the most common. We have an off-label use of tacrolimus also for this. IPL is gaining popularity, especially in the urban centers. But still, we have a real need for some multicentric RCTs to really get down to the bottom of what is cost-effective and also clinically effective. The DUSE 3 does talk about AI and deep learning, and it gives some very promising data, which is that for estimating the tear breakup time from just a simple slit lamp video, it can actually has a 87.7% accuracy in measuring that. If you give it meibography images, then it can actually diagnose those or grade them accurately with 95.6%, which is 16% better than what most specialists could do. ASOCT based tear meniscus analysis, again, it can do a very good job of 82.5% accuracy. And there are certain convoluted neural network models which can just grade your SPKs with 97% accuracy. So you do have a very promising role of AI in the future in terms of community screening with smartphone-based devices. And in our country specifically, we have so much disease burden, so many patients that we can really gather a lot of data and use that to build even better models. And this is something that can really bridge the shortage of specialists that we have across tier 2, tier 3 cities and rural cities. Obviously, SLET developed over here is an excellent thing for patients with very severe ocular surface disorders. So the basic things are that the third edition of the DUES is a paradigm shift in how we understand, how we describe and classify dry eye disease. India does have some unique challenges, but has also come up with some amazing solutions such as SLET. There are a lot of new promising molecules in the pipeline. Not all of them available in India right now, but soon they should be, and that should really help us provide better treatment to our patients. And AI, again, seems to be playing a very promising role in helping us improve our treatment for dry eye. Thank you.
Thank you, Dr. Sartaj. While we get on to the next one, Dr. Amit, your take on current management here. You can use that mic as well.
Thanks, Sartaj, for a great presentation. Not an easy topic because it's become so extensive with the DUES 3 coming in. What I understand is that the focus has shifted a bit beyond that aqueous deficiency and evaporative dry eye to something which is involving more of neurosensory pathways, and we are trying more often to try to get to the exact diagnosis. That's why we have so many subtypes which will define. So this is why if Sartaj was talking about all these cyclosporin and all these other molecules which are coming in, this is what the DUES 3 is aiming to focus on, more specific therapy, some roles of biomarkers and early and diagnosis like a non-invasive breakup time and stuff like that. So I think that is the future of it. Of course, dry is always very difficult to treat, but with these things coming in, I guess we might get better outcomes in these patients. Thank you.
So I have a question both for you and Sartaj. So how different do you think is the outcome with IPL or the standard moist heat therapy that we describe to our patient? Is it just more a gimmick, the instrument, or is there any true benefit to it?
I think maybe Sartaj has more experience, but I have used IPL for some time in PGI as well. It doesn't work in all patients. For example, it's the same way the vectored thermal pulsation or LipiFlow doesn't work in all patients. And that's why what we are trying to see, rather than seeing where it works, we have to shift focus and see where it does not work. For example, a burnt out disease. If there's so much of the glands are obliterated and it's too far, then it may not work. So sometimes we wait too long for these treatments to come in, and that's why they don't work ultimately. So I don't know what is your experience, Sartaj, with that, but there are some subgroup of patients who are happy also with IPL.
Thanks.
Small group, but yes, some of them.
I'll completely echo what you're saying, that it does work in some patients. They're very happy. And there are some which it definitely does not. And the challenge as of now is really identifying those patients. And I think that's where maybe DUES 3, by going more into the etiology and creating more subgroups of etiologies, we can help better understand that this is the particular subgroup that would actually benefit with this. But IPL is the good thing about IPL is tends to be cost effective compared to thermal vectoring technology such as LipiFlow. But in our population, some dark skin patients, you can have hyperpigmented lesions later on.
Okay.
So that's one thing that you have to keep in mind. But the mechanism of action of IPL is sort of more broad spectrum, so it'll tackle more things. Maybe they claim even Demodex and a broader variety of OSTs than just the meibomian gland, which thermal vectoring does.
Sure. All right. Thank you. So, with this, I invite our president, Professor Sushmita Kaushik, to speak on the relevance of MIGS in Indian glaucoma scenario.
Good afternoon, and thank you, Parul. So, MIGS is, as we know, the next thing and the in thing where glaucoma is concerned. And so the reason really would be why surgery, because it's a one-time attractive magic wand. But why more than trabeculectomy? Because we do know trabeculectomy has its problems. And MIGS for whom? Which glaucomas? And of course, we know in children there's no question, so we won't go into that because goniotomy is the mother of all minimally invasive surgeries. So just to put things in perspective, trabeculectomy still is our savior. The vast majority of patients who come to us are poor, they have advanced disease and they're unable to afford medications or follow-up. And this is a patient who came to us long ago, and 8 years after phaco-trab done in both eyes, this is the kind of glaucoma care that you want to see because the fields are pretty much stable, the bleb is functioning, and the pressure is 12 and 14 on one prostaglandin analog. So this is what really trabeculectomy can do for you and do for your glaucoma patients. But the problems are they have a propensity to fail, so it's very hard to keep them working. And there is a complication of excessive filtration, hypotony, a lifelong risk of a bleb with leak and infection. So that's where MIGS came in to hopefully be at least a little bit effective, though not as much as a trab, but definitely to take away the complications. So the new thoughts, of course, are to spare the conjunctiva. These are the things which are available in India. Angle-based, you can do pretty much most of it. Canal-based, you do have the eye stent and the canaloplasty. We are hoping the hydrus would soon come in. And we are still awaiting the Zen and the pressor flow in India, so we don't have that as yet. But the minimally invasive surgery is actually just a minimal disruption of conjunctiva, sclera, and iris. In resource crunch areas, low-cost MIGS would easily be a BANG, bent angle needle goniectomy, or a Tonito microhook, or if you want to treat more of an angle, a gonioscopy-assisted transluminal trabeculectomy. So the BANG is the easiest, where you just have to bend a 25-gauge needle, and of course you need to tilt the microscope, see the angle. And there you are, and before doing the cataract surgery, if you are doing phaco, I like to do it before. There are some surgeons who like to do it afterwards, but in an unopened eye, so you can see the cleft forming, and in a bit you will be able to see the trabecular meshwork at the tip of the needle. And that's about it that you need to do, and you can do 180 degrees at least, or maybe a little more by rotating the eye. The Tonito hook is similar. It has a smoother contour, there's less bleeding, and collateral damage appears less than the BANG. But basically the principles are the same. And you can see the cleft being formed. So this is an angle where the trabecular meshwork was not functioning, and you just go in with it and you remove the trabecular meshwork, and the cleft is pretty well visualized with that. GAT is our go-to procedure now when we want to treat more of an angle. It's an ab interno surgery. You use a 5-0 proline. You just make a little small goniotomy there. You thread it in, and you keep threading it in until the other end comes out, and then you can just pull it off. It has a little bit more of a learning curve than just angle surgeries, and it does tend to bleed a little more. But once you get the hang of it, you know just how much of a goniotomy to do, then it's not so difficult. And there you can see 360 degrees of the TM is just taken out, and it is more effective than doing a lesser surgery. So where does it fit in? I'll quickly go in. The best case scenario for me would be a moderate glaucoma with open angles and a cataract. So here you would, we've used a BANG, so just open it up, And once that is done, you can follow up with the cataract. This is the trabecular meshwork actually. This is that little thing there, which just gets washed out with your phaco. So continue with the phaco, put in your lens as usual. And there is a fear that it'll bleed and you may not be able to do your cataract surgery and all that. But I don't think that's true. Once you get the hang of it, they don't really bleed, and cataract surgery can go on. And it's made a wonder as to the number of medications we can take them off, and in many times the subsequent trab which we planned can be avoided. Surprisingly, it works in PACG. This is somebody who was on pilocarpine for a long time, so you can see the pigment on the lens surface, and this didn't dilate at all. But she was 56-year-old. The pressures, she required 4 AGM, so we thought, why don't we do MIGS along with it. So I'll just show you the syneculitis. So of course there's peripheral anterior synechia, so you just use that needle, pull it down, and then you can easily make the cleft in the trabecular meshwork. And once the syneculitis is done, it's easy, and I think PACG works better because it's primarily a TM problem and the outflow channels are okay. And then of course we do a bit of stretching to be able to do the phaco, and that's pretty much routine then. So the question always is, when we do a MIGS with a phaco, that it's a cataract surgery which is working in the PACG and not the MIGS alone. So to sort of do that, so okay, sorry, before we go there, we looked at our 1-year outcomes of phaco bang, and I just want to show you the conjunctiva and the ocular surface that really goes a sea change once you do a bang with the phaco, because you can see even though the pressure is not so less, but these bars show you the number of anti-glaucoma medications. And believe me, if you take a patient from 4 anti-glaucoma medications to just 1 at night, they'll be indebted to you for the rest of their life. So significant reduction in AGM use, even patients who are controlled on 4 or 5 AGMs, is a huge benefit for our patients. So more severe glaucomas, you can of course treat more angle. We are rethinking strategies. This 50-year-old woman, for instance, had PACG in the right and PAC in the left, and you can see that the superior field is completely gone with an inferior notch, but she had a clear lens. The lens vault was fine. The options would have been a trab or maybe would have been a clear lens extraction. Dare we try MIGS? So we dared. What we did was a GAT with syneculitis, and this is in 2021, and we are quite astonished at how well a standalone works in PACG eyes as well. It's 4 years now. She's still 6'6", both eyes. The pressures are 10, but now the left eye pressure has started creeping up. The PAC is getting worse. So we dared do the GAT again. So there is a bit of hyphema later, but then last follow-up in December 25, because it works so well in the right eye with nothing at all, with a clear lens, with 6'6" vision, she's off the meds again, and we hope it's going to last. So I'll just go through some beyond traditional indications. Angle surgery we've been doing now for secondary glaucoma, steroid-induced, UVI tick, glaucoma following cataract surgery. These are all conditions where the trabecular meshwork is the primary problem. And in contrast to what is traditionally believed, it does do well. In fact, we've just had a publication of GAT in neovascular glaucoma once the PRP and the anti-VEGF is done, and they do very, very well. The other thing is angle surgery after prior glaucoma surgery. So this is a patient who has a trab and it has a tube as well. And when there were too much of anti-glaucoma, you can see how bad the ocular surface is. We've actually done a phacotonito after a trab and ADI, and we've been able to bring down their medication requirement as well. The early evidence in literature is mostly 6-month data. There are few with 1 year or more. So it's an early thing yet. So we're all sort of looking into our patients and hoping that it'll last. So KDB, Phacobang, and GAT in previously failed surgery 1-year results are very encouraging. The only one that is there is a phacotonito versus phaco at 2 years, and the phacotonito has done much better. So it's not just the removal of the lens, but it's also the mix that's working. So I'd like to say that in real-world situation, MIGS is a really value addition to the glaucoma surgical field. Combined with cataract surgery, it's safe and an effective option for IOP and medication reduction. And it's across the spectrum of glaucoma. It's not just primary open-angle glaucoma. Suture GAT in our hands appears to result in the highest success rate and lower IOP, making it an invaluable addition in all glaucoma surgical decisions. I acknowledge all my residents and the glaucoma team at PGI. Thank you very much.
Thank you, ma'am. The wonderful part is to see that it's working even in angle closure eyes. Just one question. Do you think hemi-GAT works as well as a 360 GAT?
No, the more angle you treat, we've seen, the better it is. So 360 would always work better than a hemi-GAT.
Right, ma'am. Thank you, ma'am. So I invite our next speaker, Professor Usha Singh, who is the head of oculoplasty and ocular oncology at the Advanced Eye Center, PGI. And ma'am would be talking to us about chemotherapy for retinoblastoma.
Good afternoon, everybody. Respected chairpersons and friends. So I'll be talking on chemotherapy for retinoblastoma. Retinoblastoma is the most common and curable intraocular tumor of childhood. Its treatment requires a multidisciplinary team, and chemotherapy is the mainstay of treatment. The efficacy of IVC in shrinking the RB lesions without inducing long-term cosmetic defects or secondary cancers with recovery of useful vision in some cases has made it the most preferred modality of treatment of RB, especially in the developing world. It's a main form of therapy for orbital and metastatic disease too. So there has been an evolution from EBRT, that is external beam radiotherapy, to chemo reduction, as there were concerns with EBRT. So the primary objective of systemic IVC chemotherapy is chemo reduction. It reduces the tumor so that you can apply local therapies and control it. And we get almost a 49% reduction in the tumor thickness and the tumor base by 35%. And along with it can also be used along with consolidative therapies. It is known to decrease the recurrence of subretinal and vitreous seeds. It's used as an adjunctive treatment to lower the likelihood of metastatic spread following enucleation. There is a caveat. This may lead to treatment abandonment. So we need to counsel them prior to treatment not to give up halfway. So chemotherapy can also be used locally as in the form of intraarterial, intravitreal, subconjunctival, and intracameral. Indications for neoadjuvant chemotherapy would be bilateral retinoblastoma just prior to enucleation of the advanced eye, and chemo reduction can facilitate safer surgical removal. Occasionally permits globe salvage and adjunctive focal therapy. Tumors which are located in a visually critical locations, lesions near the optic disc or fovea, and it's given before focal therapy to maximize potential visual preservation. So the VEC regimen is used, that is vincristine, epoxide, and cyclophosphamide, most commonly used. And it's a minimum of 6 cycles are given at an interval of 21 to 28 days interval. And following approximately 2 cycles, once the tumor regresses and the reduction of the subretinal fluid has been observed, adjunctive focal therapies are introduced to consolidate the treatment response. The protocol is given below. The agents uses vincristine, epoxide, and carboplatin. As we can see, they all act in different phases of the cell cycle. They cause mitotic spindle arrest and DNA religation, double-strand breaks leading to apoptosis, and also DNA fragmentation leading to apoptosis. So the outcomes reported with intravenous chemotherapy are, as we can see, the group A, B, and C, the response rate is very high, from 80 to 96%. And it's only the group D which has a lower success with the 40% or 47% as reported in some. And group E has very low globe salvage rate, but it is there. And one thing is clear, that globe salvage decreases progressively with advancing ICRB group. And adjuvant chemotherapy It is given once the eye has been enucleated, and if we find histopathological high-risk features which are given adjacent, so the chemotherapy is given to these patients. Recurrent tumors in intraocular retinoblastoma, new retinal tumors, main tumor recurrence, subretinal or vitreous seeds. So it's given for to control these. And in orbital retinoblastoma, orbital retinoblastoma leads to the increased risk of metastatic disease from 10 to 27%. Hence, usually many centers would give high-dose chemotherapy, that is 12 cycles. Metastatic retinoblastoma with extension to the CNS, bone marrow, high-dose chemotherapy along with surgery and radiotherapy is used. For metastatic disease, autologous stem cell transplant is done where the bone marrow is involved, the CNS is free, and there's some distant mets. And in CNS, we are giving intrathecal chemotherapy, including trilateral retinoblastoma, where the treatment is palliative. So subconjunctival chemotherapy is not used as a monotherapy. It is used as adjunct to systemic chemoreduction in advanced retinoblastoma. It has its own side effects. The main side effect is the limited efficacy in controlling subretinal tumor seeding. Intracameral chemotherapy is used has been reported to be used in 16 eyes, especially with the patients who have anterior segment seeds without irreversible vision-threatening adverse effects. Intravitreal chemotherapy, the rationale is that the vitreous is avascular, poor penetrance of systemic or intraarterial chemotherapy. Vitreous seeds remain a major cause of treatment failure, and indication would be vitreous seeds, recalcitrant subretinal or retinal tumors. Advantages is that it increases the globe salvage rate. It may also decrease the need for EBRT and other treatments. And as we can see, the technique has been described by Francis Monier in 2012, and they have used a safety enhanced technique which has anti-reflux features, and this is how it is done. And the main thing is the needle has to go at 90 degrees at perpendicular to the globe, pointed towards the center posteriorly and towards the center of the globe, and the needle has to be frozen before it is pulled out. And triple freeze-thaw is used. As we can see over here, one of our patient, group C eye, and you can see one is right eye is a group C and the other eye is group E. And the patient underwent chemotherapy, systemic chemotherapy, and what we can see that there are localized seeds now. It was already there. And when the chemoreduction took place, the tumor seeds have broken from the main tumor mass and they've spread to they've dispersed into the vitreous. And this is how we treated the intravitreal treatment, and we are given 5 injections, and now all the seeds are gone and controlled, and patient is doing fine. The vision has been salvaged in this eye. So our study in our department, we found a 86% response, and globe salvage was 84%. ISC is a way of increasing the chemotherapy dose locally to the tumor and decreasing to the body. It could be selective and super selective. Super selective when it is directly, the catheter is inserted into the ophthalmic artery ostium and the drug is released. This was described by Abrahamson. So why ISC? That's because all IVC has adverse systemic side effects. EBRT has its own issues like dryness, facial dysmorphism, and mainly the secondary cancers. And focal therapy, they are applicable only for small lesions, and enucleation being the ultimate permanent loss of globe and vision. So indications would be primary therapy in unilateral sporadic retinoblastoma in patients more than 4 months of age, and to salvage eyes secondarily after therapy, then recurrent tumors, persistent seeds, primary modality in bilateral retinoblastoma. This is center specific, as some centers in US would not give for bilateral case in unilateral cases, whereas some centers would give for all cases, unilateral, bilateral, everything. So it's all center specific. So it is done under the fluoroscopic control, and we can see the choroidal blush. The femoral artery is used for catheterization, And coming to the globe salvage rate following IAC, so we can see it is quite good. And after a single session, there's a 33% reduction in tumor base, 46% reduction in tumor thickness. And it's given for 3 cycles of IAC are given. And this is done at a monthly interval. So at our center, we have found a globe salvage rate of 71% in primary and 87% in secondary usage. And this is how we assess the response, the tumor size, the subretinal fluid, the RD, and vitreous seeds. We evaluate each feature at every cycle. And we have got a globe salvage of 82%. Here is a patient of group C. You can see the tumor reducing, and after 2 cycles, it has almost disappeared. So here is a group EI. We wanted to enucleate this eye, but the parents were not willing, so we took up for IAC, and we could salvage this globe. And this child has a 10-year follow-up, and this was one of our first cases, and she survived. The globe survived, and she has counting fingers 3 feet. Now coming to the practical part of this advanced retinoblastoma, here is a patient where we have taken the permission for the photographs and all. So this patient presented with unilateral orbital retinoblastoma, and in October 23, you can see he received 4 cycles of neoadjuvant chemotherapy, and after that, enucleation of the eye was done, which had gone into thysis, so we had enucleated it, but we did not put any implant. And other eye remained fine. And a patient also received external beam radiotherapy. And at July 24, the patient came with while testing, his bone marrow was positive. So it was decided to take him up for autologous stem cell transplant. And this is the course of the child in the pediatric ward. It was very lengthy. The patient was kept in ICU, and patient developed, the ICU period was 2 months almost. He developed a lot of infections, gastric infections. He was loose stools, and a fever, and all mucositis, grade 3 mucositis. And he was treated with the antibiotics, and then he developed worm infestation, okay, and then he developed the CNS, sensorium was altered, and so extensive workup for the CNS was done. And all the investigations were done, and finally, he was treated for all the complications which he had. And so we can see that this child, he had a very stormy course after all that autologous stem cell. From diagnosis to he required all therapeutic support, financial support, emotional support was given. Child had developed some psychiatric problems, so he was supported. Then physically he was put on ventilatory support. And then, of course, broad spectrum, all treatment was given, broad spectrum antimicrobials and transfusion. So it was, but all these efforts were really worthwhile, because at 2 months, he was fine. He's survived all this, and we can see this, how this child has survived from 25 to February 26. And so the teams, RB team's experience in retinoblastoma, we have our own publications where we have. So the key takeaways is the IVC remains a mainstay in RB care, especially where IC is limited. Effective for primary tumors, selected recurrences, and adjunctive therapy for high-risk pathology. Extraocular and metastatic disease require intensive multimodal management, and supportive care and long-term monitoring are essential. Thank you very much.
Thank you, ma'am, for that overview. In the interest of time, I think we'll move forward. I invite Professor Jaspreet Singh to talk to us about current management guidelines of childhood myopia.
Very good evening to everyone, and thank you, COS, for having me part of this session. I won't take long because it's all about myopia, which is short-sightedness, nearsightedness. So basically, just coming to the real picture, it's a lifestyle disease. So it's not just a treatment, it's something you have to modify in your daily life as well. So what are the methods to control myopia progression? Well, we have environmental modifications, we have pharmacological therapies, and we have optical treatment and something else also which has just come up. So what are all these treatments based on? These are either based on the accommodative lag theory, or you can say a peripheral refraction, which is a hyperopic defocus. Coming to, as I said, it's a lifestyle disease, just like hypertension. You have to take medicine, but you have to decrease your salt input also. So it's just like that. So you have to increase your outdoor activities, increase sun exposure time, reduce screen time, reduced high intensity work, basically the near working hours. So just a 20-20-20 rule, what they say, to guide the general public, the children, the parents, how they should go about it. That's take a break after 20 minutes, let the child go out and see at a distance for about 20 feet for about 20 seconds. So it's like that. So coming to the pharmacological therapy, so it's a combination of both environmental modification and the other, you can say, pharmacological interventions or the other interventions what we'll do. So mostly all these studies have been done with atropine. So how to select the concentration for atropine for clinical use? Well, it should be effective in slowing myopia progression. That is what we want. You can't really just stop it, but you can definitely slow it down. It should be well tolerated by the patients. The side effects should be minimum, especially near vision difficulties. And of course, should have minimum rebound myopia on stopping treatment. So it should not come back when you just stop the treatment. So some of the randomized trials which have been done include the ones way back started in 2006 in Singapore by the name of the atropine treatment of myopia study 1, 2, 3. And then we had the LAMP study where they use a higher concentration of 0.05%, so different concentrations they've used. And then we had the Indian study from AIMS Delhi. So coming to the concentration, we have so much available in the market. I mean, it just varies. So what should we use? Is there any ideal concentration of atropine to be used? Well, you have 1%, which is quite strong. It has been tried. Definitely had a good effect, but bothersome side effects and high rate of rebound myopia. That's one. Once you stop it, the myopia tends to come back. So similar was the case with 0.5 and 1%. 0.05% has been used in trials now. Probably the most effective low concentration atropine with tolerable side effects. So the side effects are there. In a few patients, you have to stop it. But in many, they are just tolerable and you can just go on with them. But we still are waiting for data on rebound myopia. So till now, probably, if you have, you can say evidence-based guidelines, then probably 0.01% is the most effective concentration at 5 years because it has the least rate of rebound myopia and minimal side effects. So it's actually a dose-dependent effect what you're having from 1% to 0.01%. But yes, side effects, rebound myopia also have to be considered. So coming to the next part of treatment, that's optical treatment. So you have contact lenses in the form of ortho-K, you have multifocal contact lenses, you have spectacles. Now, just to tell you how they really work, if you have a uncorrected myope, so where do these rays form? So centrally they are coming in front of the retina, but periphery they are having a hyperopic defocus. So they are going beyond the retina. So that's what we call a hyperopic defocus. So if you give traditional correction, that the single vision glasses, what we call them, so here the macula, the rays will fall on the fovea, that's good. But where the peripheral rays go, going again beyond. So that's a stimulus for elongation of the eye. But if you give them optimal correction, maybe with these contact lenses, there is a what you call a myopic defocus. So that stimulus for elongation is now not there. So that's how they work. So orthokeratology, obviously, we have been tried in various, the cornea people are using it. So it's a program application of contact lenses. We have these rigid gas permeable lenses which are worn during the night. We do require detailed corneal topography for selecting the appropriate contact lens for the patients. So how do they work? Again, basically, it's they cause flattening of the central cornea, so it will cause flattening and steepening periphery because it's the peripheral rays what you want to get them into a myopic defocus because that's the stimulus. So the peripheral steepening happens and the central flattening happens. So this is how they work. So central rays are again falling onto the retina, onto the macula, where the peripheral ones are forming a myopic defocus and not a hyperopic defocus, which happens in a myopic patients. And that's the stimulus, which is the driving force for elongation. So who can use? Well, myopia up till -6 diopters the trials have been done, and there is evidence in literature that it works fairly well. The other prerequisites are definitely for any contact lens user, a healthy ocular surface, no contact lens irritability. So coming to multifocal soft contact lenses, again, two basic portions for focusing light. Central portion corrects the distance, and the peripheral one focuses light anterior to the peripheral retina, creating a myopic defocus. So they all work by creating a myopic defocus, and that's how they prevent the myopia progression. Coming to spectacles, again, the concept, the basis is the same. So these are not single vision glasses, but we have the ones, especially you can say these special myopia glasses in the form of DIMS. You have these Stellest glasses. So you have highly aspherical lenses technology. They are defocus incorporated multiple segments. So all these things, again, the basis for all these things, how they work is by creating a myopic defocus. So this is focusing in front of the retina. So all these lenses, which are spectacles, which are available in the market, maybe by Hoya, or maybe by Essilor, all these work by the same theory that they induce a peripheral myopic defocus. And something new which has come up is the repeated low-level red light therapy. Well, this is not available in India. It's been tried in China, some in Australia, Hong Kong. What they say is basically this low-level red light would increase the dopamine synthesis, leading to increased blood flow in the choroid and lead to choroidal thickening. So it's just 3-minute session twice a day. Has been shown to give fairly good results in low myopes and in pre-myopes. But yes, the complication with red light therapy need to be studied, and it's just limited to these people in the studies done in China. So these are some of the ways how you can just prevent you can say decrease the progression of myopia. The important thing is that the progression is unpredictable. So you cannot say that one thing is working in here, it will work in the other child as well. So early recognition of pre-myopes is important for prevention. That's a lifestyle disease. So increase the outdoor activities, reduce near work, which is very essential. Early use of low concentration atropine significantly reduces myopia progression in young children. Optical treatment is an effective alternative, and red light therapy is showing encouraging results. And this was something what we published, and this is all based on this publication, basically, the National Consensus Guidelines for Childhood Progressive Myopia. Thank you.
Thank you, Professor Jaspreet, for an extremely comprehensive talk on this very relevant topic. In the interest of time, I now invite our next speaker, Dr. Gagandeep Barar, to talk about the refractive cataract surgeries.
Thank you, Dr. Parul. You are about to label me as professor, I believe. How I wish I was a professor. So I'm going to be speaking on refractive cataract surgery. And are we really there? Our patients definitely want us to be there, because this is the major problem after phacoemulsification, that the patient wants to be spectacle free for all distances. And the hype is essentially created by the outcomes of refractive surgery. And the patient wants kind of Superman vision, because that's what they see in the movies. Now, when we look at the results of refractive surgery versus the cataract surgery, now for refractive surgery, more than 90% of cases will be within 0.5 diopters of the intended correction. And for cataract surgery, more than 90% within about 1 diopter. Now, for select patients, the outcome after cataract surgery can be even better than this, despite the fact that we have IOLs in only half diopter kind of steps. And both of these procedures are very safe, less than 1% kind of severe complications. And the advantage of cataract surgery is that it can additionally address presbyopia. And trying to achieve the perfect kind of outcome, what has been described, they talk about the 6 A's. Astigmatism control has improved a lot with the availability of the toric lenses. Aspheric optics were definitely one of the ways to increase contrast. Accurate biometry, all of you know that. Appropriate formulas have improved a lot. And one also must be ready to adjust the outcome after this procedure has been done, especially when you use some of these premium IOLs. And accommodation, we had an accommodating IOL available, didn't work very well. But I would say it's more like a pseudo accommodation which is available to us using a host of IOL technologies. Now, what it all entails is a detailed, proper assessment, accurate biometry, use of the latest generation formulae, and an array of IOLs available tailored to each patient's need. And obviously, surgical techniques have improved, and the femtolaser assisted cataract surgery can add no more accuracy to the results. And like I said, post-operative adjustments are also available. Now, biometry, all of you know that the optical biometers are the ones which are more accurate. And I have just listed two of the types. The advantage is they are non-contact, but you will not get a reading in 15 to 20% of cases in dense cataracts and some of these other things that you have seen listed here. Out of the two, I've given the most common ones used. The IOL Master has a certain advantage of faster data acquisition and being able to give readings in more denser cataracts compared to the Lenstar, but the downside is that it's more expensive. And in cases where an optical biometry cannot be done, the A scan is ideally done with the immersion technique so that you don't have corneal indentation. And now in today's time, you have so many formulae available that the initial 1 parameter or 2 parameter kind of formulae have gone on to an analysis of 7 to 8 elements for the final calculation. And we have these newer AI assisted programs as well. And some of the claims are that you can be close to 98, 99% within 0.5 diopters with these newer formulae. And just like I said, initially the first generation, second generation were using kind of standard ELP of 4 millimeter or 2 factors, but now we have gone on to the analysis of the effective lens position using almost like 7 to 8 parameters. And then finally coming to our journey with the intraocular lenses. Initial, like I said, the spherical monofocals were the ones which started off the whole thing with IOLs, and then we wanted better contrast, and for most of our patients the asphericity addition of whether it was 0.2 to 0.27 microns, they added better contrast for distance vision to most of our patients. And then for the last 30-40 years, as far as quantity is concerned, we also had a host of multifocal IOLs available. Initially, there used to be a refractive multifocal IOL available, but had a lot of glare and halos, and that went into kind of disrepute. But the diffractive multifocal stayed on, but the major bugbear of multifocal IOLs is the dysphotopsias that a lot of patients have, and the reduced contrast. So then the focus shifted to something new. Now the focus is now shifting to what is known as an extended depth of focus IOL, which kind of bridges the gap between a standard monofocal and a proper diffractive, full near correction kind of a multifocal lens. Like I said, multifocal IOLs, even today, they can give very good results. But the major problem is the reduction in contrast and the dysphotopsia, which is the Achilles heel of this kind of a technology. And there are some patients who are extremely unhappy following a multifocal IOL implantation. And some of our retina colleagues will also want us to stay away from these multifocal IOLs, especially in patients who may need some kind of a retina intervention later on. Now, one of the best things to happen to IOL technology in the last 20-25 years was the availability of a toric IOL. Because before the toric IOL became available, we had the LRIs, the opposite clear corneal incisions. The problem with the incisional kind of manipulation of astigmatism was that one thing is the accuracy was not that much, and it was prone to regression. So the toric IOLs made things so much easier in the sense that there was no change in technique. The cataract surgery remained the same, and the IOL took care of a large part of the astigmatism. And like I said, the newer kids on the block are the extended depth of focus IOLs. Now, when we look at multifocal IOLs, this is like distinct foci for distance, intermediate, and near with these newer multifocal lenses. And with the older generation ones, it was just for distance and near and nothing for intermediate. But now the modern IOLs are kind of stretching the focus into an area where everything is in focus at the same time in a larger kind of depth. Just like we look at microscopes with a greater depth of field, where everything is in focus at the same time. So same thing in IOLs, that's what the extended depth of focus is trying to achieve. The concepts to remember with the extended depth of focus is that these are using mostly spherical and higher order aberrations to achieve a pseudo accommodation. But any IOL which offers significantly more than one diopter of pseudo accommodation will be associated with either degradation of the distance image quality or have halos and glare if some element of multifocality is used. And the greater amounts of pseudo accommodation will also make the IOL more pupil dependent. Now, the first ones to come in was the so-called monofocal plus lenses, and the Johnson & Johnson Eyehance was the kind of the benchmark which came in the first, and it used basically based on a continuous higher order aspheric profile, giving us a little bit of intermediate vision, although it is FDA approved only as a monofocal lens, but it works like a monofocal plus. But the zonal designs give you some halos and glare. Already over? Okay. There's so many of these lenses available, and that people have started making classifications. There are 5 types of the extended depth of focus lenses. The pure spherical aberration based are these two, and there are pinhole based extended depth of focus lenses. You also have multifocal IOLs with reduced TAD, which is some of these examples that you can see. And you have these hybrid kind of multifocal EDOF lenses like you saw with the Technis Symphony. And the Lucidis and Supraphobe also you see here is more like a hybrid refractive multifocal with the higher order aberrations added. And this, the Eyehance and Acrosoft Vivity is another kind of technology with an X-waved kind of technology. These are all proprietary kind of technologies, and I would say the Pure C from Johnson & Johnson would also be somewhere in this category. Now, I'll just talk very briefly about the Vivity. It has a surface platform about 0.1 micron in about 4 millimeter zone, and it stretches the wavefront a little. And then you, in the central 2.2 millimeter, you have further shifts in the wavefront to give you multifocality kind of a situation without the added glare and halos. And the Johnson & Johnson Pure C is a slightly different technology. It uses a proprietary posterior surface, and it's a smooth profile from the periphery to the center, increasing towards the center, and uses nearly total use of the transmitted light. Now, if one were to select what lens, if the patient is desiring only high contrast distance vision, the aspheric monofocal works the best for most of the situations. Distance and intermediate vision, a monofocal plus lens. Corneal cylinder more than one diopter, a toric lens. You want distance, intermediate, and some near vision with minimal dysphotopsia, an EDOF lens. And you want very good near vision but are ready for to tolerate some dysphotopsias, then you go in for those trifocals or the CRV kind of multifocal lenses. Does it mean we are at a stage where a clear lens extraction can be done? That's really the big question. There are very few patients where a LASIK cannot be performed, and the age group is such that this may be an alternative, but it may come at a price. The risk of complications is also always going to be there. So the key takeaways are that the surgery, obviously the microsurgery has improved quite a bit. Exciting new technologies have come in, especially with these EDOF lenses. They are bridging a gap, giving us more flexibility and giving the patient greater range of vision without the added problems which we had with multifocal IOLs. And newer technologies like the light adjusting lens and all those things, we have to have more experience with those things, but we live in good times and we are almost getting there, labeling cataract surgery as a refractive procedure. Thank you so much.
Thank you, Dr. Gagan, for summing it all up. Professor Jagatram, you would have to give us your takeaway.
I think Dr. Gagandeep has done outstanding.
Sonam, I think we'll have to, Sonam, sorry, we'll have to break it because we have it this thing. So we'll take Dr. Jagatram's.
I think it was just outstanding presentation by Dr. Gagandeep Barad. We should know the expectation of the patient, and I think as he last slide he showed that what is the expectation of the patient and what IOL should be implanted is fine. That is one. Some people are happy with the monofocal, some people are happy with trifocal, some people are happy with the ADOF IOL, but 100% patient cannot be pleased. So I think we have to do counseling for patient, that what is the expectation of the patient and what is the expected outcome. Despite that, there is a tremendous improvement in the technology. Despite, I think, best biometry, best possible surgery, fematosurgery, or we do all types of advancement in the IOL, such as ADOF IOL or trifocal IOL, whatever you do. But I think counseling is extremely important, and we should tell the patient before surgery that some want 100% result, that okay, 100%. I think 100% cannot be achieved for 100% people. But anyway, we have to keep in mind retinal surgeons also. If patient is undergoing retinal surgery, we may not implant toric IOL. But a lot of patients, they have macular degeneration or they have diabetic retinopathy and other disorder. I think expected outcome should be told before. Thank you very much.
Sir, and glaucoma colleagues also. Yeah. We don't want any multifocals in contrast, which is already gone.
I have one big thing all the time going, because we see these old patients done the surgery maybe 30, 40 years back. I see these lenses are getting hazy. I'm sure you people are seeing these are getting a little opaque. And so if we are going for this refractive so-called IOL implantation for presbyopes and early, and their longevity will be 60, 70 years, how that part will be, how easy is to replace these lenses. And of course, the big population which Professor Jagat has done of pediatric, what would happen to that? I am really worried, because I see a lot of them, they look opaque to me, especially that elderly generation. It was fine when we are doing cataract surgery, old people, they live few years, their longevity was not much. So I think this aspect needs to be looked into very, very
I think the last thing is that if you have unsatisfied patient, you do your best. If patient is not satisfied, send that patient to Dr. Dogra. He is the person who can satisfy the patient.
Thank you. Thank you for that.
So with this, we come to the end of the session, and I request all the speakers and esteemed panelists to join us on the dais for a photograph, please. Sonam, you too, please. Yes, 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 yes.
You don't get this opportunity.
कुछ नीचे